that you will all learn more about how we can leverage biomedical informatics to start looking at investigating health disparities, and then starting the process of looking ways to restore health equity towards patients. So let's talk about what we're going to go through today. Today, we're going to go look into the background, talk about the Exemplar itself, how it's a biomedical informatics tool, where we developed and tested this, as well as being able to implement it for end-stage kidney disease patients. We're then going to look into asthma emergency department visits, and then wrap up with a conclusion and being able to look into future directions. Before I begin, can everybody hear me? Okay. So let's begin. So I want to first start off with this quote from a founding father of biomedical and medical informatics, Homer R. Warner, where he mentioned that medical informatics is 10% medicine, 10% computer science, and 80% sociology. That's very important because it focuses into the particular aspect that another founding father, Dr. Friedman, mentioned, that biomedical informatics is the concept of humans and computers being better than human knowledge. And this is especially important when we're going to start looking into disparities and, of course, looking into populations that are more affected or by disparities that might be propping up. And with that thought in mind, that's why we need to develop health equity informatics literature. We need to find a way to start thinking about how we can tackle on health disparities. And so a new term that I developed is to emphasize this type of research, and it's called Equiformatics, the field of investigating health disparities and the pursuit of health equity restorations for disadvantaged groups through biomedical informatics. So how does that figure into what we're going to talk about today? Well, here we see in biomedical informatics, we have public health informatics, medical informatics, bioinformatics, and all of these different disciplines are coming off from the branch of biomedical informatics. Where Equiformatics sit is actually in between these groups, where we're trying to look into how we can leverage some of these techniques to look at race health disparities, and then be able to work towards finding ways to possibly rectify them. So let's first start off with health disparity. What is a health disparity? Well, it's a gap between two different populations. In our talk, we're thinking in the respect to measurable health outcomes. There are multiple health disparities that are present, and today we're going to look into race disparities. And so race disparities, of course, are between two different populations, particularly based upon race, and they exist in multiple forms, whether it's in health, education, income. And so we're going to focus particularly on the health and medical aspect. And that's why we're going to look into health equity, which is a fair and just opportunity for everybody to be as healthy as possible. So with this being understood, there are multiple ways to eliminate health disparities and health inequities through Equiformatics. I'm going to demonstrate that too today with my work. So what are we going to do today in terms of discussion of my thesis? So we're first going to look into how we developed a biomedical informatics tool with the Exemplar. We'll look into how we use data analysis to evaluate data and possibly look for potential disparities with end-stage kidney disease, as well as with patients with asthma. And so with that being said, let's first talk about the work published in Medical Decision-Making Policy and Practice that was just published last year with the automated tool for health utility assessments, the Exemplar 2. So patients want more agency in healthcare decisions. This has been mentioned time and time again, with a lot of patients asking for that particular aspect in their treatment options. And we know that because some minorities feel like their race is a barrier for treatment in healthcare settings, where they feel that they're not being consulted or heard about their medical decisions thus wanting more agency in their decision making. So there's a possible way to get more patients involved in their medical decisions and conditions, and that's through shared decision making. Shared decision making is where patients and providers collaborate together on medical decisions for patients, where it's having an influence on healthcare, whether it's from patients who request for shared decision making to even policy developments in various government aspects. So there are multiple ways to do shared decision making. Today, we're going to focus on the health utility assessment parts about it. But what are health utilities and what do you apply them to? So we're going to go into that by looking into what we apply health utility to in the form of a health state. A health state is a condition, treatment, health circumstance that one would face during their medical treatment or the progression of a disease. This can be from something that's feeling pins and needles on your legs to something more of a curative treatment like a transplant. And so a value that we put to the health states is called a health utility, which is an expression of a patient's preference and values for a health state in numerical form, where they act as quality of life weighing factors assigned to that particular health state, where we have ranges from 0 being dead to 100 being healthy. This, of course, is a scale, but these are considered the two endpoints of those scales. With that being said, the health state being evaluated in between those scales is the intermediate health state. So with this in mind, how can we see this applied? Well, we could use health utilities for quality adjusted life years where quality adjusted life years are multidimensional measures of quality of life and survival, where in this case, we're going to look at time spent in a health state. This health state is diabetic neuropathy, where because of diabetes, you're having nerve damage that makes you feel like you have pins and needles in your legs, and you're having that for 10 years. With that being said, we can multiply that by a health utility where we have a 0.9 or 90 out of 100 as the utility, and we can multiply that to be able to get 9 quality adjusted life years. Excuse me for a second. Sorry, I didn't realize that I had turned off my camera like that. So let's go into what we can use health utilities for. We could use it for cost effectiveness analysis, patient level personalized decision models. And so with that in mind, we need tools to systematically acquire these health utilities. And so with this in mind, we're going to talk about how we can do this through objective of the Exemplar, where we want to develop a health utility assessment tool that could be able to test the usability and feasibility of the tool, as well as seeing if this tool can actually improve patients' knowledge while having their utilities assessed. And so we're going to test with common health states of type 2 diabetes, because type 2 diabetes is a common disease in the United States, and that some of these health states, including diabetic retinopathy, diabetic neuropathy, and diabetic foot infection requiring transmetatarsal amputation, these health states they might be familiar with as a result of diabetes. So let's talk about the Exemplar. The Exemplar is a health utility assessment tool that has been remodeled after a 20-year-old application that has been revamped for the web for using modern day web-based technologies. Some of these technologies are including HTML5, CSS, JavaScript, and we can use that to implement multiple assessment methods, including the standard gamble and the time trade-off. With that said, one of the great aspects of the Exemplar is that we can integrate demographic data into the process where we can acquire patients' preferences and values, as well as allow for more features to be enabled in the process. So let's take a health utility assessment project right here with diabetic complications. We're going to assume that we're an African-American male in their mid-60s, and we're going to have our utilities acquired. And so we see for the standard gamble that on alternative A, we have diabetic retinopathy there. We also have on the right-hand side, alternative B, or the pill bottle with 100 pills in there. So we could read about it, or we can see a demographically matched video clip.
Hello, my name is John Kingston. I've had type 2 diabetes for a number of years now. Over the last year, I started having trouble with my vision. I really enjoy reading books, but I've not been able to do so lately without a lot of.
So we see here that there is an African-American male in their mid-60s. I would peg them more in their mid-30s, but this patient is explaining the demographic, the health state of diabetic retinopathy to us. And because we're able to link to the patient's demographics of African-American male in their mid-60s, provided it's embedded into the project, we can bring up these video clips to explain these different health states to patients. And this will be very important for various health states that may be more complicated and may need more explanation. We'll talk about that later, but right now, it's just a nice feature for us to have. So let's talk about the standard gamble. We have alternative A with diabetic retinopathy, where you're losing your vision because of diabetes. You could choose that, or you could choose the pill bottle, which has 100 pills in the bottle. And if you choose that bottle, you have to take one and only one pill from there. If you should take that pill from the pill bottle, you may draw one of the 50 pills that you take it, you wake up the next morning, you're able to have your vision restored, you have no more diabetic retinopathy. You still have diabetes, but you could be able to go watch some of the great movies and videos that are out there, as well as read whatever book you want to do. With that being said, you could also draw one of the 50 pills that if you should take it, you will kiss your spouse goodnight and not wake up the next morning. So between these two different options, which one would you choose? Well, that's the thrust of the standard gamble, where we have it so that we have patients choosing between alternative A or alternative B, going back and forth between whether or not they're willing to take on the gamble. And at a certain point, they will be ambivalent to either the health state or the gamble, in which that case they will press equal and then their utility is acquired. Now, let's talk about the time trade-off. One of the best things about the gambler that can be implemented in the time trade-off is that we can go into the gambler using the patient's demographics and link up for Center for Disease Control Prevention, CDC life tables. From those life tables, we can bring up life expectancy tailored to that patient. And with this case, we have it for 16 years as their life expectancy. Embedded in this project, we can now assume the following. Suppose you have diabetes, you end up getting an infection on the foot, and then it grows to a point where in order to save the rest of the feet and the body, not letting it grow too out of control, it will need an amputation just below the ball of the feet, or transmetatarsal amputation. You will live with that for essentially the rest of your life, 16 years with it. On the other hand, with alternative B, you could choose that and be well with diabetes for 8 years. However, you will unfortunately pass away 8 years earlier than what you'd expect. With that in mind, which one would you choose? Well, that's the thrust of the time trade-off, where we have patients choosing either alternative A, the amputation, or alternative B, well, with diabetes, going back and forth, seeing how much time are they willing to trade off up until a point where they cannot make a decision between the health state that is being presented, the intermediate health state, or the years that they're willing to trade off, in which that case they'll press equal and have their utilities acquired. So we have a tool. Let's test it out and let's see if people can be educated with it. First, we're going to go through a diabetic complications knowledge assessment pretest, just evaluating what people know about diabetic complications. We will have them use the Exemplar and have their utilities elicited and acquired. We'll then go through a post-test, seeing how much they learn from using the Exemplar, and then do a user experience exit survey to see if the tool was usable and feasible, and overall, how did they enjoy the experience. So now let's get into the results. So we had a diverse amount of testers from around the United States, whether it was Ohio, Kentucky, Washington, D.C., New Jersey, with a wide age range with a mean of 40. We had a fairly representative cohort with gender, as well as a diverse amount of patients or users based upon race. And with that cohort, what we're able to see is that the Exemplar is able to be used within a median time, about roughly 6.5 minutes. And then the usability score had a median of 88, overall demonstrating that the Exemplar is usable and feasible to implement for patients, especially in the clinic. The testers loved the visualizations, whether it's the pill bottle, the time bar, or the video clips, including the health state video clips or the video instructions. Let's talk about, did they learn? The answer is that they did, and there was a significance in what they learned, with a change score of what they learned from the pre to post test assessments about an average of 7.6 points, showing that patients did indeed, or testers really did learn from using the Exemplar. Now, when we talk about the tool itself, about the utilities acquired, for diabetic neuropathy, diabetic retinopathy, and diabetic foot infection, what we saw for the standard gamble is that neuropathy was the most highly valued health state. The same thing with the time trade-off. Now, if you look at the time trade-off and the standard gamble utilities, you'll notice that the time trade-off utilities are lower than the standard gamble. The reason is because the standard gamble incorporates risk into its model that now makes patients tend to value health states closer to well than in the time trade-off. And this trend generally holds. So what did we learn from development and testing of the Exemplar? Well, we saw that the Exemplar is easy to implement under time constraints, that people can learn from using the Exemplar. We also saw that, just like in literature, we saw that the standard gamble had higher utilities for these testers. And then we saw that the testers found the Exemplar usable. So there are multiple comments that we could talk about, but I want to focus on the last one here. It educates, scares a bit, but does not force a choice to change a habit. That's a great comment to hear. And that's because we don't want to force patients into a decision. We want patients to learn and to be able to express their own preferences and values for different health states. And this will be especially important for vulnerable populations who will have to make harder decisions on more unique circumstances for health states. So let's talk about the future directions of how we can use a Exemplar. We're going to first focus on atrial fibrillation, and with the Arista grant we've received, for University of Cincinnati, we have patients in the healthcare system of UC Health. If they are recommended by an electronic healthcare record trigger, they will be recommended into a shared decision-making clinic where they'll use the Exemplar. From using the Exemplar, their utilities will be plugged into the atrial fibrillation decision support tool, where then they could be recommended possible treatments for their atrial fibrillation. and have a consulting and shared decision-making consultation with their provider. We can then take this internationally with pregnancy and venous thromboembolism or blood clots. With our collaborators in Canada with McMaster's University and Spain with Hosptial de Sao Paulo, we were able to implement the Exemplar for essentially patients that were pregnant and see their evaluation for different treatments of blood clots and venous thromboembolism. This work recently has had its protocol published, and that's great because people can learn more about how we're going to go through this particular assessment, especially the fact that we have to implement the Exemplar in Spanish. This makes it, of course, international with being able to support different languages, but we also have to be mindful of the fact that international laws have different international standards for privacy. And so that's what we had to face with the European Union's General Data Protection Regulation, or GDPR. So we had to be mindful of that while developing the Exemplar for international use. But we're going to bring it back domestically, but this time look into vulnerable populations with end-stage kidney disease patients and see how they're receptive to a different type of kidney transplant, one with a hepatitis C viremic kidney. So let's look into that with evaluation patients' receptiveness for HCV-exposed kidney transplants through exemplars. And we're gonna first talk about end-stage kidney disease. There are over 700,000 end-stage kidney disease patients in the United States, with nearly a third of them being African-American. For these patients, they have to be put on a machine and go through hemodialysis in order to substitute for their failing kidneys. And for African-Americans, they stay longer as dialysis patients than compared to their European-American counterparts. With that being said, we can get them off dialysis by taking a kidney transplant, but less than 4% of end-stage kidney disease patients are receiving a kidney transplant, with African-Americans having to wait longer for a kidney transplant. So then how can we possibly get them donated kidneys? Well, we can leverage the unfortunateness of a tragedy to possibly ameliorate this issue, and that's with the opioid crisis, where before the coronavirus pandemic, it was one of the largest public health disasters, leading up to over 60,000 deaths in 2018. However, as a silver lining to that issue, we had an increase in organ donor supplies, where some of these organs were just as in good quality as their non-user counterparts. With that being said, some of these organs may have a hepatitis C infection because of needle sharing, but through recent pharmaceutical and drug development, it is possible to do the following: use a hepatitis C infected kidney, transplant it to the patient, treat them with antivirals, and effectively cure them of hepatitis C, thus making them have a kidney that's just as good as a regular non-infected kidney. And that's great because nearly half of these HCV organs are currently being discarded. That means that we could take advantage of some of these organs, be able to implant them into the patients, treat them, have a kidney that's just as good as a regular uninfected kidney, and start chipping away at the waiting times for a donated kidney. With that being said, there are risks involved in doing that. And the risks is that if the antiviral medication does not work, the patient will have a hepatitis C infection. And we've seen that for African Americans, they've shown differences in risk attitude for medical treatments compared to their white European counterparts. And so we want to see if we can educate patients about these risks before they make a decision or express their preferences and values. And we're going to do that through exemplars. So then, what is an exemplar? Exemplars come from exemplification theory, where members of a group can identify with other members based upon demographics, whether it's age, gender, and race, and that a member of a group can act as a representative to communicate the ideas which will then make them receptive to the information being discussed, whether it's with smoking or with adoption of the HPV vaccine. And so the Gambler, because of the demographically matched video clips, has the ability to show exemplar video health state clips, provided that's embedded into the health state video, the project for the Gambler. So what are we gonna do? Our hypothesis is that viewing race match exemplar video clips could better educate patients, with this reflection being showed in the pre to post test utility assessments, and that post test assessments. We also would see that European African American patients would differ in health state valuations. And so our objective is to develop a health utility assessment project for end-stage kidney disease, for hemodialysis, kidney transplant, and transplant with a hepatitis C affected kidney. So let's start from the top with how we did this. We went to Dialysis Center, Inc. in the Cincinnati metropolitan area, an outpatient hemodialysis clinic. We asked patients in these 4 centers to have their knowledge of end-stage kidney disease and hepatitis C evaluated to see what they knew. We then had their health literacy and subjective numeracy evaluated with the REALM SF and subjective numeracy exams. We then took the cohort and split it into 2 different cohorts. One is race matched health state video clips, and the other one was race mismatched health state video clips. With this known, we decided to have them go through 2 health utility assessment projects, one being hemodialysis and kidney transplant. The other one is the disutility of an HCV infected kidney transplant. And while they're having their utilities assessed, they would either see race match or race mismatch health state video clips. At the end of it, we made them go through a post-test evaluating what they learned about end-stage kidney disease and hepatitis C. So I'm going to take you through the results, where before we had finalized them, this was some of the work that we had demonstrated at the American Medical Informatics Association for a poster presentation showing the interim results. So from those interim results, we finalized the study, and what we saw is that overall there was about an even distribution in the arms, whether it was on race or in gender, with overall African Americans being a majority in the full cohort. We saw that for the REALM SF and numeracy, that overall patients were fairly health literate. We also saw that they were fairly comfortable with numbers. So now we're going to look into the demographics, and what we see is that while African Americans may be younger in our cohort, we saw that the years in dialysis differed between African and European Americans, where African Americans on a median had 18 months difference between themselves and their European white American counterparts. Now, let's talk about what did they learn. Well, they did learn a lot from using the Gambler. Well, with a jump in knowledge from pre to post test, and the significance was looked upon in the change score, where we saw that essentially these patients gained about a median of 10 points from pre to post test. So when we look into the cohort split between race match and race mismatch, what we see is that while patients did learn from these assessments, unfortunately, we didn't see any differences between race match or race mismatch exemplars in terms of knowledge gained viewed in their change scores. Overall, it may just mean that the health state video clips, regardless of race, better educated patients. Now we're going to focus on the health utilities. So first, with the standard gamble, we see that for the standard gamble, we had utilities somewhat trend towards African Americans having higher valuation of health state than compared to their European American counterparts. However, this trend became significant, particularly in hemodialysis, where African Americans had a higher valuation, health utilities closer to well for hemodialysis than compared to their European American counterpart. And this may just demonstrate that African Americans felt that for hemodialysis, that it was closer to well, that they are expressing their preferences in that sense. So this was for a group, but it's worth just breaking it out into individuals. And this particular chart demonstrates this with the time trade-off radial plot. So focusing on the radius from 0 up to 100 being the utility, and then going clockwise, we see that some patients value health states relatively the same, with such as patient number 1, and some patients have wildly different valuations for different health states, as you can see, for instance, with patient 10 or even patient 38. And so seeing that, what we can essentially assume is that these health state valuations are personalized to patients, and that they're just expressing their values for these different options that are being discussed with them today. That's how personal it is, and that it can be used for further shared decision-making consultations. So what did we learn from end-stage kidney disease patients? We saw that data supported that African Americans were longer as dialysis patients. As matched up in literature, we saw that patients' knowledge improved after going through the health utility assessment process, and that African Americans for end-stage kidney disease patients had higher valuations for health states compared to European Americans. With this being said, I want to focus on what did the patients think, and what did they say? We saw that patients found the videos engaging, with certain patients moved to tears when seeing those health state video clips because it resonated with them so much. And so with that being said, patients' enthusiasm differed for a transplant with a hepatitis C infected kidney. Some patients, as we saw in the chart or in the graph, that they had similar valuations for health states. Some had larger differences. Some patients valued dialysis higher than a transplant regardless, with one patient telling me that they felt that dialysis was a blessing, and that getting a kidney transplant is not a get out of jail free card for end-stage kidney disease. On the flip side, we saw that some patients valued a hepatitis C virus-affected kidney transplant with higher than dialysis, with one patient, after hearing about taking the transplant and treatment option, said to put them on the list immediately because they don't want to be on dialysis anymore. And that just shows that these valuations are personal to patients, and that they all may differ on how they want to go about their treatment options, and thus the necessity for shared decision making. So now we're going to talk about limitations, and they both overlap with each other, but population recruitment and power collapses into COVID-19. So funny story, I was in the clinic. I had just finished up one of the major center clinics, and we'd gotten about roughly a third of our population. Then the pandemic hit, and I was stopped for about roughly 8 months. And so that made a major dent in population recruitment, and thus led towards our power deficit. And so with this being said, there are second order effects where, because of the pandemic, the shutdown, it may have shifted patients' valuations of these different treatment options and health states, which, you know, we can't necessarily test the counterfactual, but that may have influenced their valuations. So the next step is to expand the population to achieve better power results, and then do shared decision-making consultation with patients. With now their utilities acquired, we can now say maybe they should be set up for a shared decision-making consultation with their nephrologist or the providers, and essentially think about how to approach their treatment options for their end-stage kidney disease. So we've talked about end-stage kidney disease, and now we're going to shift from kidneys to now asthma, with our work published in the Journal of Asthma with unraveling racial disparities in emergency department visits and asthma severity using electronic healthcare records and machine learning algorithms. For the sake of time, we're going to focus on the emergency department visits of this work. But I do invite you, if you have the chance, to be able to read the full manuscript. So let's talk about asthma and emergency department visits. These ED visits may affect all asthmatic patients, right? But frequency of these ED visitations may differ between races. And so what we wanted to do was to investigate disparities in ED visits between your European white Americans and your Black African Americans based upon seasonality, where we looked at different covariates, whether it's smog, mold, pollen, triggering these frequent ED visitations. So how did we develop this? Well, we quantified emergency department frequency with infrequent visitors counted if they were on or below the third quartile of the population. And if they were above the third quartile of visitations, they were frequent visitors. And this is especially important because just as published in my poster for AMIA at 2019, we see that while African Americans are lower in population, they're having higher ED visitations and higher hospitalities, as well as higher mortalities for asthma. So let's talk about how we approach this. So with the Environmental Protection Agency data, their air quality data, with the Ohio Air Quality Agency data, and the University of Cincinnati's electronic medical record data, we did the following. We took these data sets, merged them and cleaned them to form a robust data set, taking the patient's demographic information, mold, pollen, and pollution data into a full data set. We then took that and used a classification that we had mentioned with frequent and infrequent visitor classification and built machine learning models such as logistic regression, decision tree, random forest, and extreme gradient boosting. Using all of these different machine learning techniques, we looked to see what was the best model and then essentially look to see what covariates we obtained from that model. So now let's look into the results. So I apologize for the density of this chart, but it's worth just mentioning that here FEV values for African Americans were lower than their European American counterparts, as well as ED visitations were higher for African Americans than their European American counterparts. So now looking at the racial disparity measures, what we see is that for African Americans, they're more frequent ED visitors at the top with the percent disparity, but they had the lowest FEV1 values at the bottom. And we were able to demonstrate that with the disparity index, showing that African Americans are fairly influenced by various covariates compared to their European American counterparts. So now let's talk about the machine learning techniques. I know this graphic is fairly dense, but I'll walk you through with it. So on the left, we have African Americans. On the right, we have European Americans. If we take, for instance, fall with the orange color, we see that there is 4 different bars: logistic regression, decision tree, random forest, extreme gradient boosting. Out of all of these models, we see that for fall, for African Americans and European Americans, extreme gradient boosting was the best overall model in prediction right here. And so this is applied to not only fall, but summer, spring, and winter too, where extreme gradient boosting, regardless of race, was the best performant model. And so why is that? That's because extreme gradient boosting leverages covariates or variables that pretty much can predict the outcome slightly better than chance, and starts building the models together with these weak covariates that can then build a robust model that could best at most probably predict the outcome that we're focusing on with frequent and infrequent visitors. So now that we've done that, let's look into variable importance. And what we see is that with the variable importance focusing from the extreme gradient boosting, we saw that taking on, for instance, winter on the top left corner, we see that certain covariates trigger African Americans and Europeans Americans the same, but certain covariates start to apply for African Americans. And the trend, whether it's in winter, spring, summer, and fall, is that for African Americans, they had molds as well as fungi being the more prevalent particulates category that pops up for this population. This is different for European Americans, where it's mixed between pollens, molds, as well as fungi as well. And so what we saw in this work was that for asthmatic patients, African Americans were more frequent ED visitors compared to European Americans. We saw that with extreme gradient boosting, it was the best predictive model for ED visits. We then saw that there are disparities in particulates between African and European Americans, where molds and fungi were more representative than African Americans, compared to their European Americans with a mixture of molds, fungi, outdoor pollen. So let's summarize what happened. Chapter 1, we had development of a health utility assessment tool, the Exemplar. We tested and validated that tool. Chapter 2, we used the Exemplar to investigate end-stage kidney disease and to see if patients may learn from Exemplar video clips, as well as their differences in health utilities between races. Chapter 3, asthma patients. We saw that leveraging multiple data sources, we were able to investigate asthma disparities in ED visit frequency. And we saw that these studies are an illustration of Equiformatics, where we're using techniques of biomedical informatics in order to investigate potential disparities and start to see if we can look into possible equity restoration. So in conclusion with the thesis, we saw that the Exemplar as a health utility assessment tool is feasible and usable to implement in clinics and for patients, where it's feasible with time as well as overall the tool itself. We saw that African Americans and European Americans differed in health state valuations, where for health states, African Americans skewed their health utilities closer to well than compared to their European American counterparts, especially for hemodialysis and the time trade-off. We saw that for African American and European Americans, these asthmatic patients differed in particular exposures that were triggering these ED visitation frequencies. We now know that we could turn this research into actionable events such as shared decision-making consultations, and then look to improve outcomes for all patients. And that's the thrust of development of Equiformatics and that is a necessity for identifying sources of disparity and possible solutions. So let's think about the future of Equiformatics. Today, we use Equiformatics for race, but Equiformatics can cover all aspects, whether it's patients that are with disabilities or LGBTQIA, et cetera. And with that in mind, we have to consider different populations throughout our investigations. What does that mean? Well, we have to understand how these tools, these data can disenfranchise and work to correct these issues. An example is that certain patients may need accessibility tools in order to use something like the Exemplar. And for instance, with health literacy, they could be able to see these health state video clips to educate them. If they are wanting to focus more on the audio part because they can't necessarily see or read the health states, we can at least play those health state video clips and they can hear what's being talked about. And we could build more on that end. We can also think about how, for instance, with asthma patient data, how if investigated improperly, we may see something that doesn't seem right in what's predicting frequent visitors. That by looking into different patients' populations, we can look into covariates like molds and pollens, and then see maybe if that's triggering them to go to the ED, maybe we need to go investigate their communities, whether it's for indoor mold pollen in their houses or even outdoor. With that being said, the thrust is to include underrepresented patients in their medical decisions, and we have to have more studies to address the root cause of racial disparities and inequities for our society. These patients are the ones that see the disparities each day. They're the ones that live it. And we need to be able to help them with biomedical informatics to be able to investigate these disparities. And through doing that, that's the thrust and the power of Equiformatics. With that being said, I would like to thank the following. I would like to thank my committee member, Dr. Mark Ekman, my committee chairs, as well as my committee members, Dr. Mersha, Dr. Shaw, and Dr. Wu. I would like to thank my collaborators. There's a lot of them, but especially Rob Ireton. I owe him a lot for how he's helped me with the Gambler. Dr. Duncan, who has done a phenomenal job trying to randomize the patients, get me into clinics, especially during the pandemic. A whole host of institutions. Some, of course, American Medical Informatics Association, where I received EMEA Leads Fellowship for traveling to a conference, as well, of course, Cincinnati Children's Hospital Medical Center, Dialysis Center, Inc., and the University of Cincinnati. Finally, I just want to take time to thank my beautiful family, Deola, Ronke, Kunle, Jin, my mother, and who's in the audience, Professor Adeboye Adejare, the professor, or my dad, for helping me out with a lot. And so I also want to dedicate this to my grandfathers, grandfather Adebile, grandfather Johnson, as well as grandfather Adejare, grandfather Isaac. Those, I wish they were here to see me today. Unfortunately, in the case for Grandpa Johnson and Grandpa Adebile, just before the pandemic hit, they had passed away. And so I just want to dedicate this presentation to all of them for being with me here today. So with that being said, thank you, audience members, for listening to this presentation. Do you have any questions?
Can you turn my video on?
Yes.
All righty. So we have one question here. Mr. Adejare, what do you feel is the next step in your study? What geographical areas, population centers do you feel would be preferable places for examinations?
So hold on, let me try to, okay, sorry, I'm gonna try to let you start the video, and you should be able to start video, Dr. Ekman. So Frankie, you asked the next step in my studies, geographical areas. So first, the next steps in the study is to be able to, for in the case of end-stage kidney disease patients, we can look into possible shared decision-making consultations and where they could think about whether or not they want to take on a kidney transplant that has a hepatitis C infection and go through the transplant treatment option, as well as if they want to just wait for a regular kidney. And there are certain studies right now that are going on about these possibilities. And, you know, if they can talk to their providers, given what they know through these utilities, maybe they can start having that conversation about where they can go next for their steps for end-stage kidney disease. We could take it further into different areas. We're thinking, for instance, if it were up to me and I had the power and the time, we would look in, of course, the Southwest region, of course, the Northeast corridor at the East Coast, and look into those different populations. You know, things that are underrepresented here, of course, Hispanic and Latino Americans, African and, Asian and Pacific Islander Americans, as well as Native Americans. They're underrepresented in this population, and it would be nice for us to see their purposes and values too. As for the asthma patients side, I think that with this knowledge, we could start to at least present out to other people about what we can do for possible remediation of and reducing of frequent visitors for African Americans by thinking about ways to combat indoor air pollution in their houses. We could probably talk to people in the public health department and just say, you know, we've seen this result. What can we do as maybe a public health campaign to be able to address these different issues with indoor, outdoor air quality for African Americans?
While we're waiting for additional questions from viewers, I've got a couple questions for you, AJ. So, just talk a little bit about machine learning techniques. Obviously, it's always a lot of excitement about it. Specifically, why do you think the extreme gradient boosting has performed?
Great question. And in fact, it's something that I know from the model itself about how it approaches it compared to other techniques for extreme gradient boosting. So the way that it's able to address these prediction values is first, before the machine learning technique, let's talk about the data itself, okay? So these covariates, whether it's mold counts, pollens, FEV values, these are not strong variables in terms of predicting outcomes. You know, like the fluctuation of mold and pollen may differ from day to day. And then in the seasonality, of course, they can oscillate from season to season. And so with these oscillations being small, they may not be able to be good at being able to be definitive in their definition of a variable. And to just kind of delve into that just a quick bit, it means that you can't just say, for instance, the increase of a mold like ascospores is almost directly related or correlates towards a frequency count. So all of these weak variables that are hard to actually determine between these two categories, they need a technique that can be able to leverage some of these weaker variables to start building the model together. This is where extreme gradient boosting shines, where it says, okay, we have this variable. Does it predict it as good as flipping a coin? And if it does, okay, we'll use that variable. What about this variable? Does it predict better than like a coin flip? No. And so it takes these variables in together and starts building that model, saying, okay, these covariates better predict this outcome than the other one. And it just keeps on building and building and robustly coming out to make a model that says these different variables, based upon their importance, predict the outcome of frequent or infrequent visitors. This is completely different, for instance, in like your deep learning, where for deep learning, you need a voluminous amount of data that are very distinct in either being high or low for classification. And that means that for extreme gradient boosting, because you only need like weaker variables and you don't need that much data to predict the outcomes, it can properly predict the frequent visitors.
Thank you very much, AJ. We have a few more questions from the audience. One question from Ronki is, how did you come up with the idea of the gambler? What were your sources of inspiration?
Okay, Adejare. It is, the gambler idea actually came from a software developed about roughly 20 or actually nearly 30 years ago. And from that software, it ran on Windows. Of course, if you saw it, it ran on Windows like 95, where if you know what Windows 95 is, you're probably older than you, Ronka, that responded to it. With that being said, we said we wanted to modernize it. And that's because there have been multiple different health utilities developed throughout the years, whether it's Impact4, some people have used PowerPoints, for instance, Shafee used a PowerPoint in order to do to do standard gamble, but a lot of them couldn't use demographic information, couldn't use CDC live tables, couldn't integrate health state video clips into it. And so that's what inspired for us to say, take this old software and revamp it for use. But then especially we focus on online because if you are a developer on the Apple iOS app or Android, that takes a long time for you to go through and get the approvals. The same thing if it's just developing on the desktop. So putting it on the web allows for easy transmissibility of the tool and allows us to essentially acquire utilities and make it feasible for doing so. And then the source of inspiration is indeed the fact that we wanted to make it easier for people to be able to have utilities acquired that were more tuned to demographics. So Dr. Preston Moore, thank you very much. So his question is, is that it rates the education participants and does it affect the decision making in the clinic. So we know that for that instance of their utilities, that it did educate them and it made them learn. Now, whether or not it affected their decisions, that's a little bit out of the scope of what we were able to do, mainly because of the fact that for these utilities, they have to go through the shared decision-making clinic next, which, of course, for atrial fibrillation, we're doing that. But it may have had them, for instance, say, well, okay, I will go to my provider and actually talk about these different options and possibly find ways to remediate them. And so I think it may actually do affect their decisions, at least giving them more knowledge about these different health states, and that once they're in a decision clinic, they might be able to decide for themselves how to approach it.
We have another question from Dr. Wu. And Danny's asking for internationalization and dissemination of the Gambler. What are the next steps? What do you need to do to ensure the tool is usable for researchers in different countries, in addition to translation?
Well, if it were up to me, I'd talk to the European Union and have some words about GDPR and how that might affect graduate students. But since I'm not a European Union citizen, we can think about next steps for internationalization. So what we've been able to do recently is develop a language pack where people that want to implement the Gambler in multiple different languages can create the state and language code for that state and be able to enter the text for internationalization, whether it's in English, it's Spanish, and we're recently testing it out with Arabic. So they'll be able to enter in that text. And then for internationalization part of disseminating it, we can then give them the links embedded for that project through CHI, or the Center for Health Informatics at University of Cincinnati. And so with that link that they get and receive, with some of their parameters custom tailored to their regions, data and health privacy considerations, they can be able to allow for the implementation of the Gambler in the international scene. Then also, what do we need to ensure the tool is usable for researchers in different countries? First, just access to the URL, making sure that the administrative tools that could develop these projects are feasible in order for them to be entering the information for the consideration of different health states, which we have done and robustly tested. We will need to be able to think more and hard about how we can make sure that for different demographics will be integrated into the Gambler. But so far, in terms of like language, text, and possible state video clip embedding, regardless of the demographics and the live tables, it is feasible to just disseminate with a link. So I'm gonna go to Shola, which is, how do you see the Gambler leveraged in underdeveloped countries where there's lesser biomedical informatics databases? Great question. I would love to implement this in Nigeria, as well as Ghana and some of the African Union countries, where one can suppose that if they want to talk about whether or not certain medications or certain treatment options are valuable, we can give them the link, give them the way to access the software through our platform, allow them to acquire their utilities, and then they can download those utilities and then be able to use it for cost effectiveness analysis, where they see, for instance, how valuable a drug is relative to the quality of life gains. And then from there, they can then use that in order to say, well, we should be focusing on these treatments, or these treatments are too expensive for us to be able to take on, and thus we may need to wait until it becomes more feasible financially for a population. So, Dr. Mersha, do we have copyright for the Gambler tool? We do, and we are hoping to make sure that the copyright is more cemented as a right. Right now, we have a personal copyright because we developed it and had it on there, as noted from University of Cincinnati. However, we will make sure that there are more protections for this IP, as this tool is very usable. We are having international collaborators from Spain, from Canada, from all these other different countries. And we want to make sure that property rights are fairly respected for IP, including what we developed with the Gambler. So this is there any more questions?
So Dr. Jones from the College of Nursing is congratulating you on your great work and asking if we were able to assess motivation for change or adherence given the education received. She goes on to say specifically motivation to improve healthy lifestyle behaviors related to their illness is so important in partnering with the providers for decision making.
So with the motivations, we did not assess that in our, for the SHKD disease, we didn't assess that. That would have been something that would have been nice. But from offhanded comments, the motivations for these patients, some of it is, you know, I'm here, I'm at, you know, whatever comes, comes. And then there's certain patients that are just motivated to get out, that it doesn't matter what it takes, that they will themselves, if the opportunity is presented to them, they would love to get out of dialysis. It's worth in mind to keep in mind how dialysis works. You go to the clinic 3 times a week to have your body dialyzed for 3 to 4 hours. You're getting up at either 6 o'clock in the morning or 4 o'clock in the morning to get yourself dialyzed in the early morning so you can catch your 10 a.m., 11 a.m. shift, or you're having to go into the clinic at a later time and thus disrupts your working schedule. And so if you could have a transplant and then be able to go about your daily life, provided you have to take medication to maintain the transplant and be able to have more flexibility. I mean, if you have that opportunity, if it means you got to take a little bit of an orthodox step, many patients will take that. And I think that's the motivation. I didn't know the second part to the question.
No, I think you answered it well, AJ. I see one last question here. Is it possible to allow the Gambler to interact and share data with EHRs?
So EHR's electronic healthcare records, thank you very much, Jin. Yes, it is, in the sense that the EHR from the Gambler for our HR population decision support tool and allows it so that when they go into the EHR and they start it, we could be able to transition patients from the EHR demographics that we have loaded up, put them into the Gambler for a health utility assessment tool, for health utility assessments, and then be able to use those utilities for another platform, which is the HR population decision support tool. So we're able to connect all those together. In the future, Smart on Fire, it is something I've been really wanting to do. However, the packages for Python, which is the literal under backing of this platform, it has been in development for a long time. In fact, I still get the GitHub repos for asking, is this project still alive? And people are trying to revive that. And so we would have to think about ways to approach that for platform distribution and getting it from EHRs from one place to another. And this is especially important because Epic, Cerner, Allscripts, all of them have different EHR standards, but they're all using Smart on Fire, and we would love to integrate that into the process.
So I don't see any more questions, and why don't we close the open? We got one last question from Yomi. Awesome presentation, AJ. What is going to be the Gambler data encoding and compatibility to other encoding? Also, are there plans for considering Gambler data mining?
Great question. So we developed an API which allows people that have access to it to be able to grab the data from the Gambler based upon either the full cohort or the particular user ID in order to grab those information for not only for the decision support tool, but also for compatibility with different applications. All of those use JSON, so compatibility is very easy for us to deal with. Data mining. Yes, we have database repositories with MySQL, and so the API will be able to allow for some of that data mining to happen. Of course, we'll need to develop those APIs a little bit more and flesh them out. However, I do see a possibility of more opportunities for data mining. And I should know, the question that people may have taken our word for, but may have wondered how, is how did we time the gambler to be able to know how long it's for them to have their utilities acquired? We have metadata installed into the gambler process where we could be able to track how long a person takes for a health utility assessment process. And so we can see a lot of data mining for there. An example is, let's say that you are, actually, before I even go further, we actually also have a easy visualization dashboard to visualize some of the data points like the health utilities as well as some of the demographics. And so in the case of the data mining, we could be able to essentially say, grab this data from the API, go look into it first for the metadata to see how long they took, and maybe you want to adjust the utility assessment project because it's taking too long, or you're noticing a certain trend of people clicking on the exact same options again and again and again, and you want to see if they're really taking something appropriately or attentive, or they need to be ways to prompt them to be more mindful of their decisions.
All right, if we were all sitting here together in person, we'd give AJ a round of applause. Virtual environment, but those of us here, well, fantastic job, AJ. And with this, we're going to close the everybody